So this is acute leukemias, myeloid malignancies highlights from ASCO and EHA. And we'll talk about five topics. First, we'll talk about oral decitabine venetoclax, results from the ASCENT-5 trial. Talk a little bit about menin inhibitors in AML. There are many, but I just mentioned the COMET-007 trial. We'll talk about rusfertide and polycythemia vera, results from the VERIFY trial, which was actually a plenary session. Talk about blinatumomab in ALL, an update from ECOG 1910, and luspatercept in MDS. And throughout this presentation, I'll kind of present a little bit kind of also the participation from our Yale investigators, and I'll get to brag a little bit about my colleagues. So we'll start with oral decitabine venetoclax in AML, ASCENT-5. This was led by Amr Saidan from our group. So most people who get in touch with leukemia know about venetoclax. It's really been a game changer in our treatment of leukemia. You see the New England Journal of Medicine paper here that got azacitidine plus venetoclax approved compared to azacitidine alone. However, it is cumbersome to administer azacitidine 7 days in a row every 28 days. So this trial tries to make everything a lot easier by offering patients an all-oral therapy with oral decitabine plus venetoclax in patients with AML. And here you can see the dosing regimen. So patients get 5 days of oral decitabine, and they get venetoclax for 28 days. As you can see, their pharmacokinetics were as expected, not changed by venetoclax. The response rate here was 46% or so, and the overall survival was around 15 months. So summary of this, the trial met its primary endpoint of response rate, no new safety concerns, and importantly with a 15.5 overall survival, which is not really much different than the survival in the VIALE-A trial that used IV azacitidine. This was 14.7 months. This could potentially represent a new standard of care as all oral therapy in acute myeloid leukemia. All right, next clinical trial is the COMET-007 trial, also led by Amr Saidan. So menin inhibitors in AML are really probably the hottest target that we have in acute myeloid leukemia right now. They're mainly relevant for two genetic subsets, NPM1 mutated leukemia and KMT2A rearranged leukemia. Menin inhibitors block the interaction between the protein menin and KMT2A, both in NPM1 and KMT2A rearranged leukemia. And it's a really crowded field right now. There are 4 major menin inhibitors, even more than that are in earlier development, and revumenib is already approved for relapsed refractory leukemia. This trial looks at ziftomenib, and it combines ziftomenib with our good old standard 7+3 chemotherapy for the frontline treatment of NPM1 mutated or KMT2A rearranged leukemia. And what you can see here is a study schema. They used the standard backbone of 7+3 chemotherapy and combined it with different doses of ziftomenib. You can see really excellent response rates here. The composite CR rate, 93%, 89% for NPM1 and KMT2A rearranged leukemia with an overall response rate of 98% and 89%. And very high MRD negative rates as well. Count recovery was not delayed in those patients, and they did not have more side effects than what would be expected with standard chemo backbone. So what is the summary? In this combination, it was well tolerated, did not delay neutrophil and platelet count recovery. There was only one case of differentiation syndrome, which is one of the concerns we always have with menin inhibitors, but only one grade 3 differentiation syndrome when combined with intensive chemotherapy. Very high response rate, as I shown here, and 96% and 88% of patients remained alive and on study at the time of data cutoff. So these data really support a phase 3 randomized trial now, where ziftomenib is going to be added to 7+3 and HMA venetoclax backbone. And this trial actually is accruing at Yale right now. One of my patients is actually the first patient who's being dosed today, and it's going to be the first patient worldwide on this trial that's being dosed. Next abstract is rusfertide in polycythemia vera, results from the VERIFY trial. I want to note that Nikolai Podoltsev, one of my colleagues, was really very involved in the early development of this trial, and the results I present here will be from the registrational trial. What is rusfertide? For the people who don't treat as much polycythemia vera, the problem is really in polycythemia vera the overproduction of red cells. In order to make red cells, you need a lot of iron. And iron is usually stored in macrophages, liver cells, etc. With low hepcidin levels, ferroportin is open and allows iron to be available for red cell production. If you give a hepcidin analog, such as rusfertide, you block iron release, and hence you reduce red blood cell production. It's a much smarter way to reduce red cells compared to what we currently do, which is phlebotomy, which just draws out iron overall, which can lead to significant side effects that patients have when their iron stores are low. So this is the verified trial that compares placebo compared to rusfertide. The study schema is here. All patients were phlebotomy dependent, so got phlebotomies. They were then randomized to rusfertide or placebo combined with current standard of care therapies. This could be cytoreduction or not. And then at week 32, the trial was unblinded and patients could cross over to the rusfertide arm. The primary endpoint was a clinical response. So how was clinical response defined? Was defined as the absence of phlebotomy eligibility. So if you had hematocrit more than 45% and it's more than 3% higher than baseline hematocrit, or 48% at any time, you were supposed to get a phlebotomy, and that was the endpoint to have not an eligibility to get this phlebotomy anymore. There were also secondary endpoints such as mean number of phlebotomies, proportions of patients who remained with a hematocrit less than 45%. That is our goal for polycythemia vera, as well as patient-reported outcomes. And here you can see the primary endpoint was met by the study. So you can see 76.9 versus 32.9 had a response as defined by the primary endpoint. And here's a nice graph that actually shows the hematocrit and change over time. And I wanted to emphasize or look at the first 32 weeks. As you can see, hematocrit rose in the patients who were on placebo, and as soon as they were crossed over to rusfertide, they had very good control of their hematocrit. So what is the summary here? This phase 3 trial included patients with polycythemia vera who were receiving standard of care therapy, including cytoreduction at that time, and rusfertide met its primary endpoint, which meant it reduced phlebotomy eligibility, improved hematocrit compared to placebo. It also demonstrated statistically significant improvement in symptoms, as well as other secondary endpoints. So rusfertide represents a potentially new treatment option for patients with polycythemia vera. So next up is blinatumomab in acute lymphoblastic leukemia. Again, shout out to Nikolai Podolsev, who is here in the room, who was a major part of the ECOG 1910 trial. What is blinatumomab? It's a bispecific T-cell engager. In leukemia, we don't have as many as myeloma or lymphoma, but this one got approved. It binds to CD3 on T cells, CD19 on B lymphoblasts, and you can see the results from the ECOG 1910 trial that was published in the New England Journal on the right here that showed that in patients who had MRD negative response, when blinatumomab was added to the chemo backbone, it improved survival. One important open question is, how do patients do who are younger, so adolescent and young adults? Do they have good outcomes with this regimen? And if yes, how good are those outcomes? And this was the subject of this abstract. The trial schema you see here, the trial protocol probably spans about 300 pages, so I won't bore you with that. But just focusing on the key part is that patients who were MRD negative after initial induction chemotherapy were randomized to either receive chemo alone or chemo plus blinatumomab. You can see here excellent outcomes for those patients who got blinatumomab and were 30 to 54 years old. So 92% overall survival compared to chemotherapy alone, 86% relapse-free survival. Two very important subgroups to look at in younger patients are, one, the BCR-ABL-like patients. Those are generally patients who have very poor outcomes with standard chemotherapy. And you can see here how dramatically the improvement was when blinatumomab was added onto chemotherapy. So 3-year overall survival, 100%, 3-year relapse-free survival, 100%, compared to 45% with multi-agent chemotherapy. So really made a huge difference here. The other group that is always important to look at is patients with an elevated BMI. So they compared patients with a BMI more than 30 versus patients with a BMI less than 30. And they saw when blinatumomab was added that overall survival, relapse-free survival was not different. And that is very important because that was always a big issue in treating young patients with ALL who have a BMI more than 30. So this is a summary. ECOG 1910 demonstrated a significant improvement in overall survival, relapse-free survival in patients with 30 to 54 years old with B-cell ALL, 100% 3-year overall survival in BCR-ABL-like patients, no difference in outcomes based on BMI. Future studies will really look at, can we now de-escalate chemotherapy now that we have such a good immunotherapy? And that will be the subject of future investigation. All right, last abstract before lunch. This is luspatercept in myelodysplastic syndromes, updated results from the COMMANDS trial. My colleague Amar Saidan was involved in that trial. Just as a reminder, how does luspatercept work? It's a TGF-beta trap, and TGF-beta is very much involved in hematopoiesis. If it's present, it can stop maturation of red blood cells. On the right, you can see the results from the COMMANDS trial that got this drug approved compared to erythropoietin. As you can see, the response rate defined as a red blood cell transfusion independence for more than 12 weeks with a hemoglobin increase of more than 1.5 was 58% versus 31%, and that got the drug approved. What this abstract was about is the now 2.5-year follow-up for those patients, so looking at the durability of transfusion independence, as well as an early look at overall survival. This is a study schema, so patients with transfusion-dependent lower risk MDS were randomized to luspatercept and erythropoietin. And you can see here, transfusion independence remained durable and significantly more durable than patients who received erythropoietin as their treatment. And then I think very excitingly for the field is that there's a first hint that the survival curves actually seem to separate a bit. This was not statistically significant yet, and this was not the primary endpoint of the trial, but we have never really seen that before in patients with lower risk MDS. All right, so summary, at a median follow-up of 2.5 years, luspatercept continued to improve response rate. Most importantly, it offered longer response duration as well compared to erythropoietin alpha. And this is the first trial that really shows a hint of a potential survival benefit. And that will require further follow-up, but I think it's a very exciting direction for the field. And here's the entire Yale leukemia program team. So it's a big team with a lot of dedicated members. As you see, we are having a lot of trials open, including registrational trials for any of the new agents that are coming along. So please contact us. I put my email there. I put my cell phone there. We're happy to get your referrals. Any questions, always welcome. So thank you very much. Happy to take any questions. Otherwise, lunch.
Okay. Wow. Any questions for Max? So you'll take a new referral anytime, day or night, right?
Anytime, by cell phone. Yeah.
You just give him a call, or Nikolai over there. You know, but no, it's just amazing the progress and very exciting in the myeloid space. Any questions? You can talk with Dr. Stahl at lunch. People are probably hungry. We've had this has been an amazing morning, and we're only halfway done.